going to talk a little bit today about the monetary ROI utilizing digital outreach and scheduling, and then put some emphasis on what the non-monetary gains are with regard to quality and value-based and risk models and things of that sort. So with that, I'm going to let Jerrod introduce.
Yeah, I'm really excited to be here today. Jerrod Ullah, CEO and founder of HealthTalk A.I. It's pretty cool. I started out my career as a neonatal intensive care nurse and been in technology the last 20 years. And there's a lot of noise around AI right now, which there should be. Finally, after 8 years, we're kind of seeing the results of that. And I think this is a really great example how AI can really bring some tangible results.
Put it up by your mouth.
Okay.
There you go. There you go.
Okay. Thank you. So, here today with Joe Monsour. He is the CEO of Allegiance Healthcare. Joe also has a cool background. He started down the clinical path, went into finance, played D1 football, and now is leading a really transformational healthcare system in rural Louisiana. So, Joe.
Yeah, my clinical path was very short. I did 2 semesters of nursing school and decided I didn't like patients or doctors. Healthcare was not for me. I was a math guy, so finance it was, that or run the football. So I stuck with finance. But thank you guys for being here to listen today. A little bit about kind of who Allegiance is to kind of set the tone for what we're going to talk about. So I tell people we put the band back together in Louisiana. We've gathered all aspects of the continuum and rebuilt the primary care base across our rural footprint, whereas now we have, as you can see, we've got a number of acute facilities, and then we've rounded out the continuum with pre-hospital ambulatory care, post-acute care, behavioral health, all in an attempt to keep in network for the purpose of trying to drive quality improvement in the state of Louisiana. So we are primarily a very impoverished state, especially in these rural markets. These are the most vulnerable patient populations that are typically the last ones to get access to care, which ends up being the most expensive model of care delivery that doesn't get delivered, if that makes any sense. So over the course of the last 13 years, my finance technology side became healthcare, and I've partnered those things together to put models together to create access to care, deliver quality care close to home is kind of one of our catchphrases. So in that process, I met Jerrod several years back, and over lots of coffee and other things, we worked through some models that have allowed us to make some massive impact in the state of Louisiana with that rural population. A side note, Louisiana has the shortest life expectancy of most of the United States. And that is primarily because there is no access to care, or there's no delivery model of creating that access to care. And that's the mission of which we've taken on to build a primary care base and build access throughout the continuum of care, whether it's specialty care, preventative care, or what that might be. That's a little bit about Allegiance. I would like to, as a raise of hands, get an idea of what our audience is. Are we providers or technology or health system? Health system? Provider? Okay. So we'll talk technology and then how we've utilized that to impact the patient populations as providers and then also as the health system. One of the things that we also did that's not listed on here, as we went down this path, we decided that in order to impact that patient population, we had to be able to help navigate them appropriately to the right care settings throughout the continuum. And the only way to do that was to have access to each one of those areas of the continuum. So we developed our own clinically integrated network to start measuring quality and report carding ourselves of how are we doing. And we quickly realized we were doing an awful job as a health system. We were probably completing about 2% of our population for annual wellness visits, which you guys as providers and health systems know, that's what starts the clock on a patient's annual cadence of their health care. determining what their risk score is and what monies are available to keep that patient healthy. So if we have a patient that doesn't do a wellness visit and they're chronically diagnosed with multiple diagnoses, and I'm having to care for them in a risk model with very little money because it was not adjusted based on their risk, I'm either going to lose money if I'm in the risk model or the patient's not going to get the care. And either one of those models is not what we were looking for. We have about 200,000 lives within our clinically integrated network that supports all of these pieces of the continuum. So in order to quickly move the needle on that wellness score and then develop the cadence of what that patient's care plan was or care path was for the next 12 months, we had to figure out how do we get them, how do we start with that most difficult to reach population. So we started with patients that had not seen their attributed primary care provider within the past 24 months. Almost impossible to do without the utilization of AI and innovation and technology tools. So I listened to a group over there yesterday, and the title of the subject matter of theirs was automation or augmentation. And that seems to be one of the things everyone looks at with technology right now. Are we going to automate or are we going to augment? And I fall on both sides of the fence. You can only automate what you can augment. So as we talk further in and we show you some of the results, I will show you how we augmented what we were already doing with automation and reallocated those human assets to other functions, other job duties. Again, the panel yesterday, if anyone listened to it, they talked about what does it look like, in 2030. And I can tell you from my perspective, we don't look today like what we're going to look like next week. It's ever evolving. So what were our challenges? I've just kind of gone through some of that. We've got hundreds of thousands of lives, very unhealthy populations, impoverished, very much unaccessible, and they use 911 as their primary care physician. So how did we grow that access? How do we staff it? We had limited technology. As we built that pyramid of stuff that we have, the acute facilities and post-acute, those were acquisitions done over years. So at one point we had 5 different EHRs. In fact, today we still have, I think, 4 or 5. How do we unite that technology? How do we create that access? And that created massive integration needs, of which HealthTalk A.I, given its agnostic nature, was able to help us bridge those gaps and really put these challenges to bed. One of the things that I tell people quite often is we didn't know what we didn't know. We know we needed to change. We know we needed to do something different to improve that population, but we really didn't know what we were doing or not doing. And once we unveiled or pulled the curtain back, we started realizing how bad we were in a lot of these measures. And for you guys that are health system again and providers, you see the trends from the MCOs and the MA plans and Medicare, and that it's all heavily weighted on value-based outcomes, risk models, shared savings models, all with the intent of reducing the expense by producing a healthier population. And so that's what we did.
Yep.
And so we started simple. We decided who we needed to reach, and again, we decided it was going to be that most difficult group, 24 months or longer, that had not seen a primary care. So we utilized the technology and the services to draw that data out of the EHRs, out of the payer claims data, and utilize that to micro-target populations based on whatever that criteria might be. Age, sex, diagnoses, geography, really whatever it was we thought.
Yeah. I was going to add that the thing was here is I think the two teams are learning to get to work together. It's all about the people and not so much about the technology. And I think that one thing we did focus on is what is the early wins we can get. So in the 6 weeks we really reached 20. We walked before we ran, right? I think when we get later on, you'll see the expanse of it. But we did show the organization and people that the technology can have an impact early on.
probably a understatement of the year.
Yep.
Some of the other things that we uncovered at that time when we started reaching out to those populations, and how quickly they responded and how sticky they became with an opportunity to get access to care, we realized just how little they were getting.
Yep.
No pre-hospital, no maternal things, no colonoscopies, no mammography. The wellness visit just started the clock. And so if you think about what that did for our volumes in our clinics, and the things that are not represented here that we'll talk about some, is what did that do then to my ancillary business? What did that do to my outpatient services, my specialist referrals, my post-acute admits, all of the things that circle that continuum? This micro-targeting of that very first population was an aha moment. I knew what we were trying to accomplish. I didn't know how we were going to get there. And HealthTalk was able to engineer backwards a solution set that was immediate, effective, and produce an ROI. I'm going to refer back again to the panel yesterday. They talked about one of the challenges in healthcare is most health systems operate at a 1.5 to 1.7% margin. So anything that's invested into the system other than the status quo, it either has to be eaten up in that 1.5%, or it has to produce an ROI quickly and move the proverbial needle. And in this case, it was a home run, which opened the door to...
I think it really gave us momentum, for sure.
Yeah. So...
Yeah, I'll take this one right here. My mic's going in and out. It's really simplified, but I think what we're showing here is that you had several different needs that we had to anticipate. We had to take care of payer, understanding the payer mix. We had to understand age, and then there was different appointment types or different scheduling requirements that we had to do based on the specific populations. Where now we started to scale out, and now we're interacting with tens and hundreds of thousands of patients at a time, but the outcomes are different based on what Allegiance's care plan needed to be for that patient population set. Yeah, so, and this is very customizable in terms of what you need to do.
This is something that my mind works differently than most. I'm a results-driven person. I sometimes am more creative than I should be, but I come up with a desired result, and then I expect my partners or my employees to figure out how to make it work, engineer it backwards to drive the result that I'm looking for. And what you're looking at is an example of one of the initial workflows, and I'm not going to try to tell you how the watch works, just tell you what time it is. I don't care how all that stuff works, I wanted the results, and we got the results. And that enabled us to then start customizing that delivery model, again, based on whatever criteria it was of that micro-targeted group, whether it was for mammography or colonoscopy again. And it set the cadence for that patient then for the next 12 months.
I think we got the next slide in terms of cadence. Oh, these are the ultimate results, So
this is through January.
Through January. So your worth of work where, we're hitting 270,000 patients in terms of interactions. For me on this slide, it's about, the last bullet, 16% scheduling rate. When we initially had that, using the agentic technology, we thought, well, what was going to happen? Is it actually going to go down over time? Are patients going to opt out? What is going to happen there? We saw the exact opposite of that. So we learned as patients actually learned the agentic technology was access to care, and that number is continuing to go up, which it was the opposite of what we thought what was going to happen in terms of that. This is the body of work over the last year.
I use my poor dad and my daughter as examples all the time. My dad's 81 years old, brilliant man, he's a PhD, and my daughter's an anesthesiologist. She's 31 years old. They don't live without this. My daughter doesn't know life without this, and I don't think my dad would allow me to take his away. So I would urge you, of 207,457 people that we outreached, what percentage would you think was not reachable via an AI SMS outreach? Keep in mind, we're in rural Louisiana. There are some people that still don't have internet. You won't guess it, so I'm just going to tell you, 2%. 2% of 200,000 people were not reachable by utilizing this tool. Now, that's not necessarily how they engaged. You have the interaction and then the number of visits scheduled. I also, you're very humble and underreporting what we have done, because a lot of this was on the initial outreach. So when that initial outreach goes out, it's live for 14 days, right?
Yeah.
Well, then we can follow up with a secondary outreach, with education, with any delivery that we want to put in that patient's hand. And so once they receive it, they've got 14 days that they can respond, and it's got agentic conversational dynamics that lead them to the trough, per se, which eventually gets them scheduled into our clinics. And then that dramatically changes the life cycle of that patient throughout the continuum. I'm going to let Jerrod talk to some of this, but I want to go back to the automate versus augment. So we have a population health team. They're smiling and dialing, calling patients, trying to schedule them. Hey, you haven't seen Dr. Bo in 3 years. Successful on a very small scale. So as we got to this point, let's augment what we're doing, augment the automation. So we reallocated those human assets to work in, my eyes are bad, to work in that block of people that declined or did not respond. Those are the people that population health team needs to work with. The ones that are engaged and involved, let AI do the work. They don't take smoke breaks, they don't take bathroom breaks, they don't go on vacation, they don't fall asleep at their desk, they just work.
Yeah, last one on this slide is that, for us, we're looking at that purple, the ones that started the integration. So, how can we use our LLM to really understand and do a better job with the folks that started but opted out? So that's where our work is still cut out for us, for sure.
I don't typically like to talk about the monetary component, because that paints a very small picture of what we're accomplishing. Although this is direct revenue driven from the scheduled visits themselves within our clinics. What this doesn't take into account is, again, all of the ancillary things, the labs, the referrals to outpatient services, to post-acute services, to specialty services, to inpatient stays. The list goes on and on and on. And then as that cadence goes across the year, and the cadence for me is going to be different than the cadence for this young lady. I don't need mammography, thank God. And it's going to build your cadence based on your historical and your documented information that is either, again, in the EHR or in a database that is pulled from claims data or wherever that might be. And I will add, I have preached for 15 years to my partner and to people across the state that the most valuable asset we have is our data, our people. And it's now ringing true, because if you don't have access to data, or you don't have a partner that can clean and scrub the data so that you can micro-target those populations, you're spinning your wheels. Huge financial impact, but that doesn't take into account any of the risk models that I'm in with payers. It doesn't take into account value-based payments, quality payments. Those far exceed what we're driving from direct billing for E&M services. Anything to add to that?
Yeah, just really quick, the 19,000 hours. As a clinician, we're not going to replace jobs. Those are jobs that can be more clinically focused. And I think that's the biggest takeaway for me here. Is great that we had a financial return. Obviously, that's why we're here. But really is like forward thinking is how you're going to use those 19,000 clinical hours
Well,
to do patient care.
That's the augmentation part.
Exactly.
Going back to that 1.5% return on our labor that we do, if we didn't have this initial impact financially to create an ROI, it would not have allowed us to continue the cadence across an annual pattern to create all of the other things that now will perpetuate themselves because we created a mission. So we're running out of time, so
yes.
If anybody has any questions, if they'll let you, I'd love to talk more. I have a hard time shutting up.
Appreciate you. Thank you, everybody.
Thank you.